with the MPH program as well. So I really appreciate having the chance to come and speak to you today. So I'll get started. A bit about me, because I know this is an opportunity for myself to introduce me to the faculty and to the students as well, for those I didn't get a chance to meet last week. I do have my PhD from the University of Waterloo in Public Health and Health Systems. Now, when I joined there, I can't even remember the year, but it was a while ago. I originally joined the program, and it wasn't actually Public Health and Health Systems. It was in the Faculty of Health Sciences, in Aging, Health, and Well-Being. And probably about halfway through my tenure there, they changed it to Public Health and Health Systems. And because I'm a director in Public Health, I just took the one that I liked more in terms of the degree and put it up on the screen. So that's that degree there. In terms of my full-time career, part-time here with CEB, I joined earlier this year. I'm the director with the Health Protection Service in Simcoe Muskoka District Health Unit. Now, I'll speak a bit about health units in general, but what I will say is that Health Protection Services in general has a number of different names across the province as it relates to what it is that service does. So primarily health protection in Simcoe Muskoka focuses in on public health inspection, and that would be the majority of our staff that we have on hand, but we also have a number of different staff members that complement some of the things in our strategic plan and some of the programs that we deliver, from epidemiologists to researchers. Within the agency itself, certainly we have a lot of nurses as well. And I'll go into a bit about this in terms of what our focus is across the province, but that's a bit about the Simcoe Muskoka District Health Unit and my role there. As it relates to my expertise and where I came from, I'm actually a certified public health inspector myself, and I won't even tell you guys the year that was, but that was a long, long time ago. So I think in terms of where my research was and where I took it from a PhD, I've always had the lens, whether it be from a PhD or a master's, to look at applicable research in the field of public health. And I think, as a result of my experience, a result of my lens, whether it be from outbreak and case management, policy advocacy, inspection, health promotion, and research, those are the types of things that I focused in on. Let's see if this works. Not really, we can just use this. So a disclaimer is really important for those in the room and for those online. And the only reason I put this disclaimer is that when I get to the actual research part, it's tough for me sometimes to separate myself from the researcher to the administrator that I am on a full-time basis. So when I conducted my research, I had to go through ethics review that you will have to go through if you go through a thesis. But certainly, because I was working full-time, I really had to do my best to separate myself in terms of the biases that I had as an administrator, and making sure that as a part of my research, I didn't bring these in. So this is one of the, you can just Google and say, the opinions expressed here, see this in a television show. This is just for me to say that I'm here as a researcher primarily on the latter half, and I guess for the most part, an administrator on the first half. So before we get into the discussion, let's set the table for what it is that's important for you to know, for you to better understand the research at the tail end of the presentation. So public health units in Ontario are extremely complex organizations. Now, if depending on where you go for information, for those that are MPH students in the room, you'll more than likely go to the Ministry of Health, and which is this acronym here, Ministry of Health and Long-Term Care website. And they'll give you a host of definitions of what it is a health unit is. They look at health promotion, disease prevention, healthy lifestyles, communicable disease inspection, healthy growth and development. This is a very generic template for what health units are and what they actually do and perform within the communities that they serve. But because of the fact that there's 36 of these health units in total, you're going to get varying sizes of these health units, and varying types of demographics of the population that you serve. You certainly will note a difference for someone like Dr. Scott here, who was an MOH in Toronto, and her population is that she would have served in the city of Toronto to a health unit like Temiskaming, which is in the opposite end of the province, where they have very different and types of populations and different types of community concerns that they will bring into their programming. So boards of health in general are, well, I shouldn't say in general, boards of health act with a board of health governments. These are autonomous bodies or corporations that act under the Health Protection and Promotion Act. Now, these boards themselves are led by the Board of Health and those members of the board that create that board. But in general, the board acts with the medical officer of health. So that medical officer of health will take things to the board as a part of that head of the organization and speak to the board about different issues, programs that would come up on a day-to-day basis. So how they operate, depending again, once you go to the Ministry of Health website, you're going to see these 36 health units, but in essence, they really operate in 4 different types of groups. You have 22 autonomous boards of health. In Simcoe Muskoka, we're a board of health that operates unto itself, doesn't have any ties formally anyway to any municipalities that it serves. And then you also have autonomous boards that are integrated within municipal structures, in those that are single-tier municipalities, such as like Hamilton. And then you have boards that are councils of regional municipalities. So, you know, for those that are comfortable or know the GTA well, you have Peel, York, Durham, that operate under an upper-tier municipality, and then there are a number of lower-tier municipalities that operate under them. So what I'm trying to paint the picture of is that these are very, very complex organizations, and in some cases very political types of organizations, because the members that make up the Board of Health from the last slide are actually people, in some cases, that are appointed through the province, but there are also people that, in many cases, are members of council from the municipalities that they serve. So it makes for a very complex and complicated relationship from a Board of Health perspective. So what do Ontario Public Health Units do? Well, if you just go to, you know, I put in Google Images and put in public health units, you're going to get all different images that come up. But everything from breastfeeding to infection prevention and control, administration of the Smoke-Free Ontario Act, or tobacco-free spaces and people. This little diagram here is of food safety. Drinking water, climate change is a big and active portfolio, I would say, within health units that really is maturing. For those MPH students here, there are a number of different health units, including Simcoe Muskoka, and Dr. Scott knows as well with our medical officer of health, Dr. Charles Gardner, who has a real passion for climate change. So depending on the institution, depending on the health unit, they will put these types of topics within their strat plan and devote resources to them. But that doesn't necessarily mean that every health unit does that. Immunization is a huge issue. That little thing there is social determinants of health, another active research forum that you may be interested in looking at. Healthy eating, emergency management, pregnancy, substance abuse, another big portfolio as well, and recreational water too. So, let's go to the next slide here. So I won't spend too much time going through this, but these are 2 of the fundamental documents that guide public health units in your day-to-day activities. So there's two documents here, and for those that are interested in pursuing a research program that looks at public health units, because I'm hoping that you will have a look at this, these are 2 documents you're going to want to be aware of. And the Ontario Public Health Standards operate under and are part of the Health Protection and Promotion Act, which is the document on the right side of the screen. So the Health Protection and Promotion Act certainly acts like a Bible for public health units. And this is the act, the statute, the legislation that in many cases, depending on the week, if it's a really bad week with a lot of outbreaks and issues that are coming up, we'll be referring to this document quite frequently along with the regulations under it. As it relates to the public health standards, these come out, or they should come out once every 4 years, and they're updated frequently based on a number of different issues of what the province expects public health units to administer as a part of their programs. So what does the OPHS, Ontario Public Health Standards, include? Well, again, have a look at it, but it includes a number of different topic areas that really guide what public health units do on a day-to-day basis. Everything from chronic disease and injuries to family health programs, infectious disease programs, environmental health programs, and emergency preparedness. Now those are just the actual headers of these subjects, but they go into very specific details. These are the guidelines, and then they have another layer under that, which are protocols, which detail specifically, you have to do this many inspections in these types of facilities. You have to have an emergency management program. You should be vaccinating school children. These types of things are implicit within the actual structure of these documents. The Health Protection and Promotion Act, I know this is going to sound funny, but this is one of the pieces of statute that most people don't know about, and it won't wow you when you actually read it, but it's actually one of the more fascinating pieces of statute that we have in the province. And there's a number of different reasons why. People watch Outbreak, right, the movie from a number of different years ago, and say, oh, wow, the government couldn't do X, Y, or Z. Well, this is one of those pieces, this is one of those documents that actually allows you to control population in so many different ways. And of course, that's going to the extreme that rarely, if ever, happens. But the powers that it provides the medical officer of health are extremely, extremely powerful. And that power obviously is used in very specific situations because for the most part, the topics that are incumbent within the HPPA are for day-to-day activities. But if you ever wanted to know, well, what can a medical officer of health do within their community? Well, everything from community health protection to, speaking about communicable diseases, to quarantining, which most people are familiar with, rights of entries and appeals. Other municipal agencies are, like police, for example, are in many cases fascinated with the powers that are provided to the medical officer of health to enter and close certain establishments that they are responsible for under the HPPA. So I'd encourage you again to have a look at that. It really is a fundamental piece within public health units that they're responsible for. So if you're interested, again, going to the Ministry of Health and Long-Term Care website, what you'll see is, and I'll only spend a second on this, but there is a ton, for those statisticians in the room, there is a ton of information, available information for analysis, just waiting to be analyzed about what public health units do, the communities that they serve, et cetera, et cetera, et cetera. So again, I encourage you to have a look at the ministry site for these specific tables just to get a sense. So let's get into public health units and wicked problems, because I'm sure people, when they heard the topic area, were saying, well, what is this thing that is a wicked problem? And I'll get to that a bit later on. But what wicked problems are really tough and complicated problems. And I put a few things up on the screen here that I'm sure most people will be familiar with. And these are wicked problems such as climate change. This is, what's that one in the middle there? Top middle. You guys don't know that one? I thought that you guys would get that one. That's Ebola, right? AIDS, from obesity to tuberculosis, and again, climate change or emergency management. But these are wicked, and the reason why these problems are wicked is because you're not going to be solving these anytime soon, right? And the reason why you're not going to be solving these anytime soon is because they're so complex. They involve so many different organizations, so many different people, so many variables that affect how these things are public health nightmares that it's going to take a lot of people, a lot of time to get to what the solution is to these issues. So there I was as a PhD student or an MPH student like yourselves, and thinking about what the heck am I going to do with my career? I've got all these problems here as a public health practitioner. So what am I going to focus in on? Well, the easy answer is I'm going to focus on pepperoni. Right? So what am I talking about? Why pepperoni? Right? Why ready? And what this is really setting the table for the research. Is what my focus was of the research that I did a number of years ago was on ready-to-eat foods. And ready-to-eat foods with the focus on public health units, because myself in 2008 was a manager within a health unit that was dealing with a very significant problem. And for those of you in the room old enough to remember, that was the crisis of maple leaf foods. So there was a huge outbreak, a number of different people, unfortunately deaths that were associated with this outbreak. And as an administrator at that time within a public health unit, I noted a number of different challenges that were associated with that outbreak as a result of working within the health unit at that time. But, you know, the question you're always going to ask yourself as a researcher is, who cares? Why is this important? So why it's important is ready-to-eat foods in general is a $1 billion industry in Canada. It represents roughly 6% of what you or we as consumers will spend on a day-to-day basis as it relates specifically just to ready-to-eat meats, as an example, on your grocery bill. They're consumed, I think we know, daily by millions of Canadians, but they're consistently recalled. Consistently, and most people aren't aware of that because in many cases it'll just take a few snippets out of the news and you'll see, well, you know, product X was recalled by the Canadian Food Inspection Agency due to, you name the organism, Salmonella, E. coli, Listeria, Campylobacter, et cetera, et cetera, et cetera. And if you actually subscribe to the CFI website, I think many of you as consumers, like we all are, would be surprised at how frequently this actually occurs for the products that we consume on a daily basis. So I think most of you are familiar that foodborne illnesses associated with some of those pathogens that I just named are very, very underreported to public health units. There's actually a mandate with physicians to report suspect foodborne illness to public health units. Now that doesn't preclude that we do get tons of calls on a daily basis about suspect foodborne illness, but to find that needle in a haystack, which in most cases people have the flu, they get sick, they have vomiting, they have diarrhea, they just don't feel well that day, most people won't associate those symptoms to what is actually afflicting them. So therefore, despite the fact that I think City of Toronto did a fabulous job in terms of reporting, the actual models of reporting for foodborne illness would suggest that it's exponentially higher in terms of what it actually is being reported by public health units. So that's why it's important to us. And foods in general that we eat on a daily basis, again, people don't realize that there are a number of different agencies that are involved in that inspection of that one product on a daily basis. And in some cases, different types of legislation will dictate how they inspect it. So this screen here is just a snippet I took a couple of days ago of, you know, some of the things, some of the products that you'll see on the CFI website with the organism that I decided to focus in on, which was Listeria. Specifically, again, going back to 2008. And then, of course, someone's going to ask, well, why Listeria, which I'll get into a bit later on. So why are ready-to-eat foods so complicated in this regulatory environment? It seems that it should make sense that if there's a regulation, we should all be following it, and we should just go inspect these foods, and we should be moving on. But really, there's three different types of platforms in which a ready-to-eat food product could be inspected under. So for federally inspected products, these are products that can go across Canada at any time. You'll see that Canada stamp on the bottom right-hand corner of the screen. You probably noticed that. These are products that can be distributed anywhere in Canada along with internationally. Those products are inspected by the federal agency, which is the Canadian Food Inspection Agency. So local public health units, for the most part, don't have any role to play in these products. Provincially inspected products are those that they can manufacture them in the province, say Ontario, and they can be distributed within the province of Ontario, anywhere in the province. But again, in some cases, health units will inspect those. In some cases, they won't. It really depends on a host of different variables, how much product they produce, how often they produce it, what types of foods. It's a very complicated formula which was just released through the Ontario Ministry of Agriculture and Food, which will dictate if the health unit gets involved. And then you have your local butcher that may produce some ready-to-eat foods, as an example, using meat, and those individuals will be locally inspected through the health unit. So for health units in general, the question really is, in some cases, as it relates to ready-to-eat foods, is who's on first? Because in many cases, it's very, very complicated to understand where a product comes from, who inspected it, when was it inspected. Labeling comes into play as well. So it's extremely difficult for us to figure it out. So I set the table a bit for you in terms of what are these wicked problems. And when I was originally looking at this topic as an area of interest, one of my professors at the time said, well, that's a wicked problem, and I sort of laughed. But it is actually a terminology within the scientific realm which describes problems that are difficult to solve, have many interdependencies, multi-causal aspects. There really isn't any clear and correct solution as to why it's happening. Think again back to the research in terms of listeria and these types of products consistently happening. No one really knows why. Well, we know why listeria replicates, but why is it actually happening in an environment that's supposed to be so tightly regulated that that ought not to happen? There's really no clear and correct solutions. The problem itself has many stakeholders, large span of responsibility that I just spoke to you about. The solutions themselves usually require some fundamental behavioral change. Think about sexual health. Well, there needs to be a behavioral change in order to stop the practice or the transmission of that specific virus. And problems may be unstable and evolving. So I can tell you this from experience, again, administrator hat on as a director, that in many cases, as it relates to wicked problems in general, health units very much feel, and this is not me speaking on behalf of everyone, but in many cases, because these problems are so complex, sometimes you feel like you're on your own island, that you really don't know where to turn to get the solution for these specific problems. So in an ideal public health world, and this really started to scope what I was going to look at for the purposes of my research. In an ideal public health world, what you would see is research, and there's lots of research out there in any public health topic you can put in the top of your head, will speak to statute, regulations, laws, because if the research says X, and I'll have an example for you in a second, well, surely, from a practice perspective, that statute, that law, that regulation should dictate what we do in practice. So, without further ado, I'll give you a good example. So, beef tenderizing. You probably thought you wouldn't see a picture here of Rocky today, right? So, beef tenderizing, by the way, this is not the way that beef is tenderized within the beef industry, but let's look at how it is. So, beef tenderizing is a mechanical process in which you get slabs of beef going through a conveyor belt, and then you have 1,000 different or so syringes that essentially smack that meat or cut through it in 1,000 different pieces. And what this does is it creates this tender steak, right? Everyone likes tender steak for those that are meat eaters. So this is what happens in an industrial environment, and this happens actually quite frequently. So why it's a risk? Excuse me to any of the hardcore scientists in the room. This is a very simple depiction. But in a nutshell, for those, because I did see from last week that there were some people that weren't hardcore scientists, so I tailored it toward that. The steak surface itself, as it's going through that conveyor belt, is a contaminated surface. It has to go through an abattoir. It has to go through processing. So as a result of that processing to get to that steak, it's contaminated, and it's expected it would be contaminated. And inside of the steak, depending on the research that you look at, would be considered somewhat sterile, right? Because it hasn't been contaminated yet. But what happens is once it goes through that conveyor belt and you have all these syringes going in, well, it's just mechanics. You're getting these syringes, it's puncturing the surface, which is contaminated, and therefore the inside of that steak environment, perfect pH, available water, very, high in protein. This is the perfect environment for microorganisms to replicate, right? So that's in a nutshell why this is a problem from a scientific perspective. Why it's also a problem is that, well, most people, when they eat that steak, they probably are one of the 1, 2, 3, 4, 5 different levels of how they like to eat that steak. There's very few people at the bottom there. And, using an old food safety acronym about E. coli, which is a big problem within that type of steak environment or beef environment, 71 and it's done. For those old enough would remember that. 71 means at 71 degrees Celsius, you are going to destroy E. coli. The problem is that if you're in one of these first few here, the probability of that destruction, in particular if you're the black and blue type, is going to decrease exponentially. So there's always the possibility that you could get sick. So when this started to really become a problem is there were a number of different research papers that I'll get to in a second that were identifying this as a huge deal, right? People were getting sick as a result of this tenderized steak, as a result of these being reported to public health units and us trying to figure out through our management of those cases saying, what did you eat in this past week here? And we figured out, and we put the pieces together, that steak was actually to blame. So between 2000 and 2009, you actually had 5 documented outbreaks of E. coli in which 174 people got sick specifically to this process and these types of food products, and 1 person dead. Is that an accurate depiction of how many people probably got sick? Not a chance. But those are the ones that were reported, probably the ones that were significantly sick, had to go over to the hospital, and they actually had, the golden investigation in which you know that this person was infected with this steak on this specific day, which is extremely difficult to do. So the research was available. It was out there. It was available. And so there was this whole public health domain of research that we knew that this was a problem. But it's extremely difficult to change statute like that. But public pressure, a number of different variables came into place. And what happened in a very short order of time is the Canadian Food Inspection Agency said, we got to do something about this. So they very quickly changed their statute. And what they said was, well, not to the degree that most public health units would want it, where we would like to entirely eliminate the risk and say, no more beef tenderizing. Well, they said, well, we'll still allow it, but we're going to warn you as the consumer. So in very, very short order, you started to see this out on shelves where they're warning the consumer that this piece of meat has been tenderized, and therefore it is recommended cooking to a minimum internal temperature of 71 degrees Celsius. And then they would have the inspectors, a part of the CFIA, go out to these facilities and make sure that that label was affixed, and if they weren't, they would have to go through enforcement and an entire process of figuring out why, where they could be charged, et cetera, et cetera, et cetera. So again, it's a very linear process, but it's a very it makes a lot of sense. You have research, you have cases, you have a change in statute, and then you have practice on the field, which actually, hopefully, decreases foodborne illness from actually occurring. So how do public health units work within this environment? Well, research for the most part within a public health domain, there really isn't a lot of primary research being done. Now, folks either in the room or on the line from Toronto Public Health would probably disagree with that, but again, funding, to the types of position that each health unit would like to produce, for the most part, is what I would say, primary research is very rarely done because the capacity simply isn't there for public health units to devote the time, energy, resources, and in particular, I'll stress time, that it takes to do fundamental, key, peer-reviewed research that you're able to publish. So what do they rely on? Well, they rely on secondary research that you saw on the few screens prior to. Legislation, really as public health units, they are, this is the statute part, they are gatekeepers of that legislation. If the legislation says to the public health unit, do X, they're supposed to do X. And of course, a part of that role is to advocate to the Ministry of Health about changing that statute, but I'll get to that in a few minutes. And then practice. Remember back to the Ontario Public Health Standards about practice. It dictates what it is that they have to do on a day-to-day basis. But then you also have these things, which will be another topic for another day, about accountability agreements. But these are agreements between the Ministry of Health and the actual health unit about what they think, the ministry thinks public health units ought to do. Do a certain number of inspections on a yearly basis. How did you do it? It's a reporting piece. So that plays into a number of different things about how public health units operate. So let's get into the study. The study itself, why I did it, again, number of large-scale outbreaks that were that made me think that this was a significant problem, and the research dictated as such. Of course, a number of different recalls. Listeria itself, although it's not, you'll probably see when you start looking at Listeria, if you get a chance, it's less than 1%, makes up less than 1% of the types of foodborne outbreaks that are out there. But what it hits with a fury. And that's why I decided to look at this, because there's two types of listeriosis that you can get from eating or ingesting Listeria bacteria. One is invasive, one is non-invasive. The non-invasive form really speaks to the general gastrointestinal illnesses that we would all equate to food poisoning, nausea, vomiting, diarrhea. The invasive form, however, is quite unique because if you are diagnosed with invasive listeriosis, you have a 1 in 4 chance of dying. That's extremely unique in the public health forum. That's almost like an Ebola type of thing. You get Ebola, well, you have a very small chance of living. So another point of why I thought this was an important piece of research to conduct, because when we think about salmonellosis, everyone thinks, oh God, salmonella is so bad for us. Well, it is, don't get me wrong, but in terms of its case fatality rate, less than 1%. And again, this is a significant industry within Canada that's worth noting. So, gram-positive bacteria, ubiquitous, meaning you can find Listeria everywhere. The unique part of Listeria, in particular ready-to-eat foods, think about the composition of ready-to-eat foods. Never look at the sodium content for any ready-to-eat meat. You will be astounded because they're very high in sodium, very high in salt. But Listeria is able to withstand extremely harsh pH, salt concentrations. It can grow at 4 degrees Celsius. Anyone here know the legislative mandated temperature for refrigerators in food establishments in the province? 4. That's the maximum or minimum type of temperature. So you're seeing a microorganism that can replicate at the legislated temperature. It's a concern for immunocompromised people and the elderly, for pregnant women, especially in their first trimester. Has a very low incident rate. There's no doubt about it. But again, it has a and again, another unique piece about listeriosis, very, very long incubation period, 3 to 70 days. Your typical ones, E. coli, salmonellosis, campylobacter, usually 24 to 72 hours, which most people can recollect what they actually ate. Well, think about if I asked you, what did you eat 70 days ago? Chances are you have no recollection of what you actually did. And you have evolving product compositions. Go to the supermarket and look at how many products, ready-to-eat products, you will see nowadays that say low sodium. Higher sodium, decreased bacterial loading. So lower the sodium, the inverse happens, higher bacterial load. Cost of illness associated with this is based on modeling. at $28 million annually in Canada. A small percentage of that is going to be associated with the invasive form. The majority of which this modeling accounts for is for the non-invasive type, which speaks to the second point, and the third point as well. So, current challenges. The processing and distribution of these foods in Ontario is extremely complex, as I was alluding to. You have federal agents, you have provincial agents, you have local public health units inspecting products mostly on their own islands, right? In some cases, very few cases, going back to the HPPA in 2008, there was one health unit that actually used that statute to go into that federal facility, which was the City of Toronto with Maple Leaf Foods. That was a very unique circumstance because typically health units and federal institutions, they don't enter, but they use the power of the HPPA in order to gain access to do their own inspections. Very rarely occurs. Now here's the difficulty of this, is that products, according to the federal standard, cannot exceed 100 colony-forming units per gram through the stated shelf life. But think about it from a couple different perspectives. Pregnant women and the elderly. It only takes one microorganism to cause that illness. So you have products that are legislated and federally legislated to carry up to a certain amount of bacteria, and this particular type of bacteria per gram. So there's a risk out there for the public, for those that choose to eat these types of foods. Lack of laboratory testing for enumeration. As a public health unit, if you get this as a part of a foodborne investigation and you send it to the provincial lab, they will tell you whether or not it has listeria or not. If you want to know how much, does it exceed this 100 CFUs per gram, well, it's got to go to Winnipeg for the purposes of enumeration, causing more delays as people could potentially be put at risk. And product labeling is a challenge. Go to your local gas station, you'll see those hot rod pepperoni sticks. Well, those are shelf-stable products. They can be put at any temperature because their sodium content is through the roof. But then go to your local delicatessen, and you'll see people start to push the limit, right? These are people that may not be in the know about that salami, those different types of ready-to-eat foods, cheeses, and they may be out at shelf-stable temperatures where their available water, their pH, their salt concentration should dictate that they should be refrigerated. But who's the gatekeeper for that information? That's the problem. So the process flow map is a mess. And this is a mess because to get to one product, that sale, in many cases you have all these different organizations and trying to inspect it. I'm not going to bother going through it, but really this is the process flow map for one federally inspected product in some cases. So a number of different organizations, and anyone with any organizational research will know the more people you get into the room trying to do the same thing or different types of things, the more complicated it becomes to ensure the safety of those different types of products. So study purpose was to focus on Ontario public health units. I didn't go into this research thinking I was going to solve this problem whatsoever, but I wanted to look at one entity of that process flowchart and say, okay, so what is it that we're focusing in on? And it's really to determine how public health units address the wicked problem of listeria and ready-to-eat foods in their food safety inspection programs, and develop some type of theory as a framework for the next steps. So remember back to that matrix that I have. The central research question was, do Ontario public health units practices, regulation, used research and innovation, knowledge translation through experience to effectively address ready-to-eat foods in food premises, which are food establishments, to reduce the burden of listeriosis? So really, does the regulation does it speak to research, and does that research and regulation speak to what it is actually inspectors do on the field in public health units? So public health legislation pertaining to inspections or inspection is in many cases quite dated. If you look at an actual statute within the HPPA, in many cases you'll see RRO 1990, that represents the time in which that entire document as a whole was last updated. So the HPPA is RRO 1990. The Food Premises Regulation, RRO 1990. It's 2015. That's 25 years in which the entire document was looked at as an entire entity for updating. Something tells me between 1990 and now, there's a lot of research available out there that has been done or will be done in order to update this to what the research dictates should be done. There's a healthy amount of food production, food safety, pathogen research available in peer-reviewed research, which speaks to listeria as a whole. In particular, after 2008 happened, wow, people were just going crazy, right, in terms of producing research specifically to listeria, recognizing it was a problem. So the sample, in terms of the study itself, was sent off to all 36 public health units. The focus was public health inspectors and management in general, MOHs, directors, managers, supervisor. You had to be eligible to participate in the study. You had to have some experience, 3 years. You had to work in food safety, the food safety program, or be a part of it. And if you were an inspector, you had to be certified and/or a medical officer help. There were a number of different phases within the study. So if you chose to participate, you could choose to participate in either 1 or 2 phases of the study. And the theory itself, my background was in quantitative research. This was a semi-qualitative research study that focused in on these interviews and using grounded theory. Again, have a look at this in terms of qualitative research to dictate how we were going to answer the study. So this was its own wicked problem unto itself in terms of trying to figure out how this study was going to flow. But it was a very complex study. It looked at a number of different phases to get to the results. And the results were that 27 out of 36 health units participated. In general, that's a pretty good ratio for those health units that are available. Phase 1 had 3 health units, Phase 2 had 8, and Phase 3 we had a majority of the health units participate in a web evaluation that went off to them. So results, study themes, and participant comments. So this is where the rubber hit the road in terms of the study itself. Again, think about this. This is either managers, directors, public health inspectors, medical officer of health saying the risks associated with ready-to-eat foods and their preparation can be dangerous for people that are in long-term care facilities where vulnerable populations reside. So certainly there's a recognition on a whole from public health units that this is a risk to a certain part of the population. But in terms of the span of control as a public health agent within a health unit, some people said public health units have little control with regards to these products since they enter the food premise in a contaminated state that we, public health inspectors, can do little with. So again, there's a lack of control. Think about yourself as an inspector going in, trying to figure out where this food came from, is it safe, et cetera, et cetera. Well, there's not a lot of knowledge there or confidence in some of these products. And we, public health units, have minimal or no contact with either agency, being the CFIA or the Ministry of Agriculture and Food or the processing plants in regards to their inspection. So again, there's a gap there. So results, there was, as a part of my research and looking at grounded theory, they asked you to look at, okay, so what's the study core category? What would be a few words that would represent what people are saying? And there was 2 things, reactive and regulatory practice. What that actually means is that public health units really deal with these types of products and this wicked problem in a reactive manner, meaning they're going to go there, they're going to look into issues associated with recalls or outbreaks, and they use the regulation, remember RRO 1990, to dictate how they're going to deal with these products. So you're starting to see some of the problems that are associated with this. And they really manage ready-to-eat meats or foods and listeria through general population and reactive regulatory processes, as I said. They focus on local level. Again, their span of control, they want to focus on what they can actually control. People in public health are sometimes very controlling. They want to go and focus on what they can actually do. And they're looking at established risks in inspected food premises. So what does that mean? Well, it means that the regulation from a public health unit perspective as it relates to this study and this wicked problem is responsible for directing more or less everything that an inspector does within an actual food establishment and dealing with these products. Food safety inspection investigation activities, growth mechanics inhibitors, government outbreak summaries are really available to public health units, but based on the results of this study, they're not really being used in program delivery. So they're not making any tangible change in what public health units are doing when they actually interact with these problems and these microorganisms within that environment. And really, innovation and knowledge translation aren't really influencing the inspection practice, which is concerning considering the wealth of knowledge that's available out there to public health units to assist them with these types of products. So really, there's a break in this bridge, and that bridge is saying that the regulation is dictating what we do in practice, and yet that practice, or the results of that practice, whether they be outbreaks, recalls, or the inspections themselves, are leading to some good research, but there's no connection. There's no knowledge translation or innovation happening where the research is going back to the regulation to make a tangible change. So, of course, with any study, there were limitations. The sample size was relatively low in terms of the number of participants, but if you think about it from the number of health units that participated, sample size was actually relatively high in general. Generalizability of the results, this is where I struggled a bit, where I said, well, the focus was listeria and ready-to-eat foods, but were they generalizable to other products? I think yes. Of course, you can't say that in research because it didn't focus specifically on that, but this is a general problem that we're dealing with foodborne illness as an issue. The interview method varied depending on where they were taking place, so I did not travel up to all the way to Temiskaming. In some cases, I would have to use a phone. And phase 3 surveys were done through SurveyMonkey, so in some cases, you never actually knew who was actually answering the questions for that. So implications, just a few more slides. Implications, ready-to-eat foods and listeria really is a wicked problem, and this study showed or reinforced that. Amending the Ontario food premise regulation from training perspective of public health inspectors, labeling is a huge problem that they identified through the study. And those HACCP principles, this is hazard analysis, critical control point, that is sort of the fundamental and guiding principles of what a public health inspector does within a food safety environment, are things that still need to be better reinforced within the regulation. And embracing innovation, collaboration, and applied research, there's a lack of communications in general that all the health units that participated spoke to about one organization speaking to the other. And really the last implication in terms of what I personally learned is that using a qualitative methodology to get these answers was in some cases much more effective than using a traditional quantitative means of gauging what people thought about this wicked problem. So, with that, I will welcome any questions, and these are just some of the people that I acknowledge anytime I present this research. But again, I appreciate the time and your patience with going through this study. Thank you very much. So, any questions? And I'll repeat these for those online. Sure. Thanks.
I know you're working with us. I heard recently that there is a movement to bring in more ready food, similar to where there may be under the table, right? Making them all. That's regulation, that's really, but people want access to ready the purpose for regulation is a problem. I don't know, is this another area of research, or is it another policy that you're concerned about? It seems to me that that's another layer on for it.
So as much as possible, I'll try to encapsulate that, but I think some of the, Dr. Scott was suggesting that there is a movement towards increasing access to ready-to-eat foods through methods or places such as Uber, which will directly transport that food from a source, person's home, to the consumer. So is there available research? I certainly think that there is. That is a regulatory nightmare. I think, currently in the city of Toronto, they're dealing with a problem with taxis and this type of issue with Uber. I would say that the problem itself of unregulated food premises and a health unit in general is not a new problem. I think the transportation or the ease of access of that will make it even more wicked. So yes, I would suggest that it is an issue. That would be an extremely challenging research project to undertake as a result of getting people to sort of admit or and trying to get that attribution between source and actual product. So I do think it's valuable research, but I also think that it would have a number of challenges for sure. Other questions? Yes. Okay. The question for those online was in respect to my personal endeavor, I guess, within this realm of public health, how I came to that, and why I decided to move on with this research. Is that correct? Well, I mean, as I had mentioned, my bachelor's degree was in public health, and a component of that was public health inspection. So when I had finished my bachelor's degree, it was at Ryerson University, and one of the things that you could take away from getting that degree was you could certify to become a public health inspector. In order to certify to become a public health inspector, you had to work within a public health unit to do a practicum, and that practicum ranges, or it's a 12-week practicum, in which you were involved in all aspects of public health. So there's a number of different criteria, time, hours that you would have to devote to it. And sort of as a result of that, as a result of practicing as an inspector for a number of years and then getting involved in the administration, that's what really prompted me to get involved directly within this type of research, because I recognized it as a problem. I mean, in general, I would say that the public health unit is extremely multidisciplinary. There are a number of different MPH students from a host of different programs across the province that are directly involved in work within public health units, and that's outside of the nursing and inspection realm. So I would say that certainly there is a lot of opportunity, but also a lot of opportunity for some really valuable research and applicable research that could be done by students such as yourself, that the public health unit could use immediately, depending on what the scope of it was. Any other questions? Yes? So I'll just, the best of my abilities, try to get that question through. So it was in regards to the number of health units out there because of the spread of distribution of those health units, different communities that they're in, how, as a member of one of those health units in respect to foodborne illnesses, how we approach the centralization or sort of coordination specifically in regards to foodborne illness. I would say in general, it's a thesis unto itself. And I would say that as it relates to foodborne illnesses, because of the underlying, excuse the word, underreporting, or lack of a better word, underreporting of foodborne illness, I would say for the most part, clusters which encapsulate different health units having to work together, they happen, thankfully not that frequently, but they're typically associated with larger gatherings. So I would say that we do most work with other health units as it relates to foodborne illness for these types of larger events. The fundamental thread amongst public health units and outbreak food management is really surveillance. And that was one of the pieces that came out of my recommendations from my research, that generally surveillance as it relates specifically to listeria is very, very poor. And one of the reasons why it's poor is that the incubation period of 3 to 70 days dictates that less than 1% of the time where it's actually reported, it makes it very, very hard to go through a survey with somebody that had listeriosis and say, okay, Fran, so what did you eat 2.5 months ago? So it makes it extremely difficult in order to get that, to make that match. And that's why the maple leaf outbreak, we were really hoping as health units in general would really start to mend some of these fences or mend some of these gaps, fill some of these gaps. I think in many cases the reports that came out federally helped us through a number of different federal surveillance networks that are now available to us, but it's still very decentralized, I would say, and specific to the health unit to make those types of associations. Yes? Well, as Fran knows, there is a number of different networks and databases, provincial databases, that we share as health units, IFAS as an example, where we're able to track these types of trends. So in some cases you'll see in the news, well, not as often as we would like, where they'll say there is a spike in a certain type of organism and we as public health units don't know what it is. So in the summertime you can almost guarantee you're going to see a spike in Campylobacter, Salmonellosis, E. coli, and the reason is, well, it's warmer, right? The temperatures go up, people cook outside, they're not thinking as much about food handler safety, things like that, and you'll always see a spike. But then you'll get some unique circumstances in the middle of the winter where they say, well, we can't figure out, we've got this, this Salmonella typhi that seems to be proliferating throughout the province as a result of these databases, and we don't know why. Despite the interviews that we have with the positive cases, it is certainly a good realm of research. I would say from a statistical perspective, I would say that the epidemiologists that are responsible for it do a tremendous job in it. But I would say locally, in working with a public health unit, yeah, there's certainly a lot of research to be done that could help in this realm. Yes. Another question? Yes. Mm-hmm. Good question. The question was in regards to outbreaks in general, including maple leaf, and whether or not those types of outbreaks are associated with improved communication to those responsible business owners that may be responsible for making those products. The answer is the Health Protection Promotion Act dictates whenever a foodborne illness is reported, the health unit is obligated to follow up with that. So the communication line starts right away. So if you say, oh, I got sick from Sam's restaurant, they would go to Sam's restaurant to investigate it. Once clusters start to happen, it makes it that much more open in terms of the communication line. One of the realms of research that has been in general not underreported or under-researched, but I've noticed as a practitioner that certainly norovirus is coming up as a significant public health problem that is typically associated, because of its symptomology, to foodborne illness. So think about a wedding as an example, which is the typical one that you're going to see. You're going to see a big outbreak. It's usually in a wedding, right? So you get a call in a health and you say, well, yeah, we're at this wedding and there's a cluster. There's 5, 10, 15, 25 people that are ill. And they say, well, what were your symptoms? Well, nausea, vomiting, diarrhea. It was short-lived, and now I'm fine. So it's very difficult, A, to isolate that virus from a public health laboratory perspective, and then isolating within food, which accounts for a very small percentage of its distribution. As a medium for people to catch it, norovirus, it's typically associated with hand-to-mouth contact. So think about a wedding: kissing, hugging, dancing together, drinking. All the things that are associated with with a wedding will assist in it spreading very, very rapidly. So what will happen is that virus unto itself will utilize a majority of a health unit's time, and the focus will traditionally be on food, right? It's got to be the food because the symptomology points to it. But at the end of the day, in rare cases where people decide to submit their stool for analysis and norovirus comes up, at an increasing rate, we are less and less surprised by it. So it had very little, if anything, to do with the food, but it had something to do with a common virus that spreads throughout the community that is a concern. So I would say, getting back to your original question about communication, the lines of communication, in particular to business owners, are quite frequently open throughout the process. Yes, one more question. The question was in regards to a decrease in, or salt content in general in foods, and decreases in cardiovascular disease. Fran would be very familiar with this. Food safety and healthy living sometimes do this. And for those online, I'm putting my knuckles together, they butt heads. Because as a food safety professional, I love salt. Right? I love salt. Put in as much as you want, because I know if you up that ante, you decrease your pH, your available water, everything goes down. The chances of you contracting anything but heart disease goes down like a rock, right? So food safety people, we love salt. You want to add some more salt in there, go ahead, knock your socks off. The other side of the health department down the hall, they're, whoa, you got to decrease your salt content, hypertension, cardiovascular disease. There's so many different types of issues that are and afflictions that are associated with salt content. So I would say it's going to be, we all know who's winning the battle, right? Just go to your grocery store and see decreased sodium, decreased salt content. We know that food safety is not being compromised, but they're losing that battle, right? We know that, food safety, salt is bad for you, right? But again, it comes with its challenges. So I think it's an excellent question. I'm glad you raised it, because, in many cases in public health units, there is a lot of that. When we start talking about schools and, dietitians and public health inspectors, we love each other, but we fight a lot, right? So it's tough because, there's two sides of that public health coin, and it's an extremely wicked problem unto itself. Good question. Any other questions from the group? All right. Thank you.
All right, thanks very much, Stephen. Great talk. I want to thank all the students for coming here. I wish you all the best with the MPH program. And I invite you to come to Rounds every month. It's every third Wednesday of the month at CEB Rounds, but all the CEB programs are welcome, so please keep us in mind. And see you next month.